This conference will now be recorded.
All right.
All right. So my article was basically a literature review on sobering centers. So places where EMS can take people who are intoxicated, specifically ETOH intoxication, to a location that is safe for them to sober up that is not the emergency department. Um, it also evaluated EMS's role in triaging those patients and the appropriate way to triage the intoxicated patient. So MD 487. So going through the PICO questions, the population. So like I said, this was a literature review. The organized authors of the article basically used PubMed and oh, oh, sorry. They use PubMed, Medline, a bunch of just databases to look at any kind of article that had the quotes sobriety center, EMS, alcohol, and serial inebriate. So by doing this, let's keep happening. They're able to pull about 2,300 articles that had something to do with those like key phrases that were searched. And out of all those articles, they reviewed 35 that were included in this review. The what is happening? The exclusion criteria. Do you guys keep seeing my whole page go back? I'm sorry.
Yep.
Exclusion criteria. They had basically two people that went through all of these articles, and they just excluded ones that they deemed not to be relevant, or any article that also included information on like treatment of medical conditions beyond the alcohol intoxication, or any long-term residential treatment of alcohol abuse. So the intervention, it was, are we going to take them to the sobering center and compare to people who were, ETOH intoxicated going to the emergency department? Now, the outcome that they were kind of looking at, they basically it just showed that there's limited data that shows that in various places around the country and around the world that there is some benefit in reducing potential healthcare costs, to help decrease the frequency of utilization of the emergency department for those who are frequently intoxicated and come into the emergency department. So they just concluded, based on their literature review, that sober centers can be utilized for ETOH abusers, and it can reduce healthcare and other costs associated with the patient population. There's not really a very perfect way like where this one fits in. It was a literature review, but it wasn't therapeutic or diagnostic. It's just, hey, there's this idea that we could use these centers. So these questions aren't all exactly right, but just going through what I had. Is the clinical question sensible and answerable? It is a sensible answer. Anyone who's worked in the ED knows how often we have the intoxicated patient come in, and it is a burden, and it takes a lot of time. It takes up an ER bed, and when things get busy, it's tough to just have someone sit intoxicated in in the hallway. The search for the studies, was it detailed and exhaustive? Yes. Like I said, they went through PubMed. They went through several literature resources, and they were able to find thousands of articles and narrow it down to 35. So I thought they did a good job going through that. The primary studies were of high methodological quality. Not really. So I actually went through several of the papers, and most of them are retrospective cohorts or case series, and that's just because the nature of this kind of question that they're asking or what they're looking at, you're not really going to have randomized control trials. You're not going to really have prospective cohorts where you're going to take and make people drunk. It's all, retrospective in nature. And that's not to say that, it's not good data, but it's not going to have the same quality as different kinds of trials or different kinds of studies can have. The assessment of studies were reproducible. Yeah, so they had different case studies. They had one in Houston where they looked at sober centers there, and you could do that if you were able to create a system in your own city. Say if we did it in Newark, and you could see what other places did and try and reproduce it and see if you can have similar findings. With outcomes clinically relevant, this was not really a clinical discussion. It was more about resource utilization, health impact on cost to the healthcare industry. Was there low heterogeneity for estimates of sensitivity and specificity? That is not really applicable here. All the other questions I didn't find very applicable in this study. So key tables. So I thought that this, oh my goodness, I thought that this study was very interesting, and I like the idea of sobering centers. Personally, I've had friends who've been in drunk tanks in San Diego, and I know that they don't just take everybody to the emergency department like we have in Newark. But some of the data I found was very interesting. So just going through the CDC, the authors, they were able to extrapolate using CDC number that there was over 1 million ED visits. This was in 2017 for uncomplicated ETOH intoxication. And they didn't really define what uncomplicated ETOH intoxication meant, but based on the actual paper, I believe it's just anytime someone is drunk and there's nothing else medical going on, someone is just intoxicated, either they come in or someone calls EMS and they need to be monitored for a period of time with no other medical issue. In 2006, estimations are $24.6 billion in healthcare costs associated with the intoxicated patient. And that's just a crazy number to me. The diagnosis, if you have a diagnosis of ETOH intoxication, your relative risk of being a frequent ED utilizer is 2.4. That's pretty high. One of the papers that they cited, Hamilton et al., found that frequent utilizers had a median of 5 CTs and 20 X-rays per person. This study was over a 3-year period. It was a retrospective study. And in that same study, I think they had like 350 people responsible for like 30,000 ED visits. So it was all like high utilizers. And then Klein et al. Found that a median length of stay of that intoxicated patient in the emergency department across the country is about 348 minutes. So 6 hours, 5 CTs. The average cost of an ED visit in these studies was about $3,000. And if you compared that to the cost that they had relative, if they just went to a sobering center, I think it was like something $400. So a lot of money can be saved. So this is an issue. Basically, what this slide is demonstrating. So what is a sobering center? The way that the authors defined it based on Warren et al.'s definition was a facility where actively alcohol intoxicated clients can safely recover from intoxication, including alternatives to jail and emergency departments, as well as drop-in centers. All of the sobering centers that they reviewed were government funded, and their budgets were not that much if you look at just average healthcare dollars spent or these patients, I guess, cost the healthcare system yearly. I thought one of the best examples of the sobering center model was done at the Houston Recovery Center. So the Houston Recovery Center, their claim to fame, they had a reduction in public intoxication jail admissions from 20,500 to 835. That's incredible. And with that, you had 23% of those people who ended up in the recovery center get admitted to long-term. They basically got involved in their version of like an AA system, a system that can help them get sober. And then Shooter did a budget impact analysis in 2019, and they were able to estimate that by diverting 50% of the visits from the emergency department to sobering centers, you could save between $230 million to $1 billion, and that's just 50%. And even if you could just do 10%, you could divert about $100 million annually, which I thought was amazing. Then the next thing that they kind of talked about was EMS's role, and I guess that's where what we want to focus on as well. Ross et al. Basically, how does an EMT or a medic who gets called because somebody's altered or on the street or laying against a liquor store, how are they able to evaluate that patient and triage them appropriately to go from the ED versus a sobering center? So Ross et al. Evaluated, they had a checklist. It was like a field triage checklist, which I have here. I thought was kind of interesting. here. So what they basically did here, the steps are kind of laid out here. It's very, very generic stuff. Assess physiology, anatomy of the injury, mechanism of injury, kind of your basic checklist that, and I guess any provider in any kind of setting is going to do if they're meeting a patient that they've never met before. So they found that using that triage policy, that they were able to safely triage people appropriately with only 0.6% rate of any low acuity adverse event and no high acuity adverse event. I did look at the paper. I couldn't see the whole thing, so I didn't get to see exactly what the low acuity adverse event was, but probably nothing serious, right? Now, in this paper, the Ross et al. One, this was I think it was also a retrospective cohort, and they actually only triaged about 20% of their patients to the sobering center. So this number, I mean, they're not taking most of the patients that are altered or intoxicated to these sobering centers. It is a very specific group of people. And one of the main things that was discussed in the article is the biggest reason why people had to go to the ED is in their protocol and their checklist of who's going to go where. One of the things was, can the patient walk on their own? And the second thing was, does the patient cooperate with EMS? So those were the two biggest issues and why so many of the patients ended up going to the ED anyway. But going back, if we were able to triage 20%, that could be $200 million in healthcare dollars saved, and that's very important. They had Cornwall had another triage method. Again, I couldn't actually access this one, but they had a yes/no survey. EMTs were able to identify 93% of patients who were able to require hospital admission. Several of the other articles that were in the review had specificities in the low 40s for who needed to go to the ED, but sensitivities were much higher, 95. One of them had a 99%. So it was actually really, really interesting. For the external validity applicability, so it doesn't really affect my care per se, but I think that this is something that EMS systems, around the country should definitely consider adopting. There are a lot of things that need to be worked out as far as triaging. Most of these care centers are staffed by care providers, EMTs, or nurses. So you're still going to have, a healthcare provider there to help triage the patient, to help, make sure that they're okay, and that there is another step past just the field triage of the EMT before letting them into these sobering centers, just to help ensure safety. I think it's a good idea. I think it could save a lot of money. There is a lot more research that has to be done. Like I said, most of the papers that were cited in a lit review were, case series, retrospective, cohort studies. But I think that there's a lot of promise in having these systems applied, especially in busy urban environments like ours. Houston, Baltimore, Washington, D.C., those were some of the other locations where these sobering centers have been implemented successfully. And I think it's a really good idea. Do you guys have questions?
When you were working EMS, did you ever have to transport someone to a sobering center?
So in San Diego, it was all by PD. So PD would come in and they would just say there was no EMS involvement where I was working.
Okay, yeah, that's why I was also very interested in this because of the the San Diego experience. I read all the articles leading to this review article, and this is sort of on the lines of ET3, alternate destinations for patients. One of the biggest things from a provider standpoint and as an organization was exactly what we were saying. Like, you need to have a protocol in place that says, hey, these are the criteria you have to meet in order to go there. Because of course, we're always worried about the patient who, they were drinking, but, do they have a head bleed right now? Are they altered because of their alcohol, or are they altered because, something else is going on? In my experience, I also work at a center in New York where we actually have a stabilization center, essentially across the street. It's run by the county. They don't take direct admissions from EMS, but as soon as we rule out or we feel comfortable saying that, this is just alcohol, they can go and hang out at the stabilization center until they're sober enough to leave, or, unfortunately, because of the congruence with psych issues, they're sober enough to either be admitted to a detox or inpatient psych or inpatient admission for something else.
And then
Anyone?
what's the like? What do they look at to kind of what do you have a protocol, or is there like a checklist in place to kind of like how do they divert those people?
Essentially, it's a checklist. So they actually, right now, the way it's set up, they don't get diverted there until they're evaluated by an ER physician.
Oh,
So there's a potential there for them to just go there, because we also get people who come directly from there. Maybe someone sent them the night before, and you know what, they haven't really sobered up, so they ship them back to us, and then we do more workup at that point. It's not unlike
gotcha.
just putting someone in the hallway and just observing them. I
Yeah.
don't know if Matt is on the call. Like, for the clinical staff, has there been any thoughts about this, or what are your thoughts? All right. Anyone else? Yeah.
Yeah, hey, Chris, it's good to see you guys again.
Hey.
It's interesting. I used to actually work at one of these detox centers. In Colorado, detox centers or, these sobering centers are very common. And I know that actually from working in the detox center that our job basically was to monitor vitals, monitor their alcohol levels, monitor their level of awareness, and really what we were constantly reviewing and looking for was any sort of red flags that would say that this patient was at risk. And we had both police and EMS that would refer patients to us directly. But if we saw anything that was, unusual or anything that was concerning and all that, we could either decline the admission at the door and basically say like, no, this is a person that needs to go to the hospital, or we could, then call EMS in order to bring them to a hospital if we felt that there was something unusual going on. And we checked on them like every hour or two, just to make sure that, everything was going okay. So I'm actually a really big fan of this, and I think it works really well. The other interesting thing is if you decrease, or I mean, if you have them go to an emergency department and then you refer them to one of these centers, and we're still charging for a emergency department visit, then I think you're going to blunt a lot of the effects that you're going to see from cost savings by, having them, seen in an ER anyway, because them sitting in the hallway, that's not the expense. It's the actual ER visit.
Yeah, so one of the other papers, I don't know if it was Baltimore, but basically they had they had a specialized unit to go out for suspected intoxications. I think they were specifically looking at like opioid overdoses, and they took those patients to a sobering center as well. And like that sobering center had like people like peer specialists and a lot of resources for detox and for other kind of abuse issues. And if you're able to kind of create an alternative system, so like PD and EMS don't have to, I mean, not necessarily like waste their time, but I thought it was also just another interesting thing that I had never seen or heard of before, where you're having like just people who are specialized in that thing going out to those calls to kind of help manage resources as well.
It's similar to the mobile crisis team for suicidal or psych emergencies.
Yeah.
Philadelphia,
That was-
that's similar to what you're describing, Dan.
Yeah, that was similar to when we wanted to put in for the buprenorphine program in Camden. That was the initial thought, and that was my initial job actually, was to drive around and just go to overdoses and just deal with those crisis patients on the EMS side. And we looked into trying to get like these drunk tanks or anything like that. The problem that we just kept on running into was the bureaucracy of New Jersey and how much it would cost, the funding, and you could put all the numbers in front of all the administrators and say how much you were going to save, and they would just, it was so hard of a sell.
Hmm. I wonder
Yeah.
why. I mean, why New Jersey when you have these huge cities all across the country that it's working successfully? That's so weird.
Well, it's because it's who it's costing them. So even though you're saving healthcare dollars, whose money are you saving? You know, from the ER standpoint,
Gotcha.
you're trying to take patients away that even though a lot of them are not collecting anything on, you know, it's still a bill, it's still volume to the ER. So if you're saving them money, you're not really saving them money. Or it's this magical funny math money that, you know, you're saving them, but in reality, now you're decreasing their volume, so now their funding, even though from other sources, are going down.
Hmm.
So
Yeah,
the bigger
because
city, because they are self-funded, you're saving them money, so that's why. And you're still sharing your screen, by the way. Right.
yeah, the state
Yeah,
does
no,
reimburse for each of those uninsured or, you know, like those kinds of ER visits, and so the hospitals are going to lose the funding, and the states are the ones who are going to save the money, and so you know your hospital networks are not going to be super excited about that.
Yeah. This is not something that I would promote, but just so you know, the fact that we pronounce more people in the field is taking a lot of money away from ERs. Because even though the staff on the ground is like, oh my God, why did you bring this dead body here? That's essentially a critical care chart that they can't bill for now. I mean, it's better medicine to pronounce in the field, but if you're talking about healthcare, economics and stuff like that, that's patient.
This came up last year in a conversation that we were having with some of the folks from San Diego, and it all depends upon what problems they're having at the time. You know, if I think at the time that there was the program and similar programs were successful in San Diego, they were having incredible overcrowding in the ERs. They were looking for ways to shift volume that they felt was just a distraction from people that were sicker. So, you know, some of this is right place, right time. Some of this is, you know, right budget, you know, or the right person pushing. As Matt said, you know, politics. So.
Right.
You know, I foresee a lot of these, a lot more of sobering centers, stabilization centers to become more popular as ET3 rolls out, because now as an EMS agency, you can develop a policy where you're bringing patients to these areas.
I feel like insurance companies would be like the biggest winners in all this, right? Because they're, I mean, I guess it did say like only 10% on average of like the bills from the like the alcoholic and like the intoxicated patient actually gets, you know, comes back to the hospital. But I mean, wouldn't insurance companies could be potentially saving all this money, or like Medicaid be like huge proponents of this?
So in most cases, it's not private insurers. In most cases, it's public safety net. So Medicaid, Medicare in some cases, but usually Medicaid. The way the hospital dollars are allocated in New Jersey, it's not actually specific to the individual patient. It's based on your prior volume that year of payers in that mix, and then you get X number of dollars that year in the hospital. And so again, you know, each state does Medicaid a little bit differently. The way we do it in New Jersey is you get a reimbursement to the hospital for the uninsured care, and then you get the reimbursement to the hospital for the Medicaid care. And it's not always necessarily paid in the way you would think that it is. So,
Or well, in a way that makes sense.
yeah.
Gotcha.
The other problem with some of these places, specifically Craig can attest to this as well, because we work at community, and patients that are brought directly to the sobering centers or the detox facilities down in that area, they get a breathalyzer at the door, and if they're above like a 0.1, they get sent to the ER. Even though they have medications there, even though they have nurses, even though they have EMTs, even though they have people that can theoretically care for these patients and a doctor overseeing that, they ship them to the ER, even though they're clinically sober, walking and talking. And I don't think this is unique to that area, especially because when I was working in Connecticut, they didn't have drunk centers at all, because there was a case back in the early 90s where they brought somebody to a drunk tank who was actually a diabetic and DKA, and this was back then. And since then, every single person that's supposedly intoxicated is brought by EMS to the hospital, no matter what, in Connecticut. So it's, you know, those are two different situations. So you got to have a lot of buy-in, and you know, specifically as far as ET3 and that stuff goes, you're going to have more physician oversight, or, you know, liability protections. You're going to have more screening, and whether that comes down to EMS figuring out how to do their screening, or, you know, even if it's a simple blood sugar check or something like that, there's a lot more to it than just saying, okay, we can divert these patients by just a simple checklist, because you never know.
Mm-hmm.
All right, if no one else has anything for that, let's move on to the next article.
Is my screen still being shared?
Nope.
All right. Thanks, Bob.
See, this is before I wanted to. You guys just see a white screen, right?
Yep.
Interesting. Anytime I make it full screen, it goes to a white screen. So I'll just do it this way. All right. So I actually ended up doing 2 articles, so that's why the title is kind of ominous. So nebulized medications, the next frontier. This is me, MD 423. So these are the 2 articles. The main one is the first one, nebulized ketamine used for pain management and orthopedic trauma, by Sergey Matov and his colleagues at Maimonides. Sergey Matov has been doing a lot of non-opiate pain management stuff for years, especially in the setting of the opiate epidemic. And then the second one was an article that I've found very interesting over the years about nebulized naloxone for opiate overdoses. So same PICO questions. So for the first study about nebulized ketamine, it was basically just a case series where they looked at 4 specific patients. They didn't discuss how they came across these patients. They didn't talk about how they recruited them, how they chose these specific 4. So I would imagine it's some kind of a convenience sample of, I was working that day and this sounds like a good option. It was a 10-year-old male, a 72-year-old female with only a history of GERD, a 28-year-old male, which at one point they said was 26 and another point said was 29, and a 39-year-old male with hypertension. There was no exclusion criteria. Their intervention was using this device, a breath-actuated nebulizer, which is different than what we carry in the emergency room that I've seen, and different what we carry on the trucks. And they used, for 3 of the 4 patients, a 1.5 milligrams per kilogram, where they put it into the nebulizer, gave it over 15 minutes to see what pain control was. The reason they used this machine versus what we're typically used to is when you inhale with this BAN, you actually get about 96% of the medication actually inhaled, versus the nebulizers that we use on the trucks and most of the ERs, we lose 20%. So we only get about 80%. And that's obviously because of the exhaust valves. And even if you use the face mask, it all has to do with them breathing in. So if they're not breathing in, it just gets lost to the air. So these are the 4 patients specifically. So it was all ortho stuff. So the 26/28/29-year-old male was a reduction of an anterior shoulder dislocation, performed by the Davos technique, which is what's in this picture. Basically, he had his arms taped around his knee and basically was able to self-reduce in a way. A 39-year-old who had a subluxed lateral patella, a 72-year-old female who had a displaced radius ulnar fracture, and a 10-year-old male who had a reduction of an angulated radius fracture. And I mentioned it on the next, one of the next slides, but the 72-year-old female also had a hematoma block performed by orthopedic surgery. In addition to having the nebulized ketamine, she also had the nebulized ketamine at half the dose. And one of the limitations I mentioned at the end of the slide for this specific study is they talked about how they took their dosing protocol from the OR literature where they use nebulized ketamine for a sore throat after intubation. So it's not really a standardized pain.
"60 Minutes," and this is the chart taken right out of the article, which says that they did. It also includes the adverse side effects, where the first two, the 28-year-old male and the 39-year-old male, just had some dizziness, some nausea, and feelings of unreality. And the other two, the extremes of age, didn't have any adverse side effects. No secondary outcomes. It was just a matter of strictly does pain control achieved or not, and do they have side effects? So the author's conclusion has been you could use it for sore throats. You can use it. It's an option for pain control. It's an option that's non-narcotic with minimal side effects. And each patient was able to leave the department, but they say more research is needed. It was a pilot study, and most pilot studies are basically bare bones, just kind of like this one was. So I had some questions that could be brought up. Is the hematoma block a confounder? We don't know. It says that the nebulized ketamine was used first. The patient, specifically the 72-year-old female that had the hematoma block, had pain control, and then they had ortho do the hematoma block. Is that a confounding factor? We don't know. Probably not if she had pain control, but they also don't list in any 4 patients what time it took for them to have the start of the nebulized ketamine to when they had pain control. They didn't talk about vitals. They didn't monitor any of that stuff, so we don't know if were there side effects from abnormalities in vital signs. Was there side effects due to dosing? We had a 150-kilo man that had the derealization. Maybe his dosing was too high, even though it was a per kilo dosing. So maybe it should be ideal body weight, not actual body weight. It's something to consider. It's not something that we can kind of use prime time yet. I'm sure there'll be more studies on the horizon. Ketamine is, for the last few years, has been the go-to thing. Something that maybe we can try in the ER as a pain control, but I don't think it's ready even for EMS yet. But something that can, like I said, consider for the future. So quality checklist. Is it a case series that's conducted in more than one center? No, it was at Maimonides in Brooklyn. At least they didn't mention if it was done at more than one center. It was only 4 patients, so I would imagine it's when Sergei Montov was working. Were the aims of the case series clearly stated? Yes. Is their case definition clearly reported? Yes, they had pain control, which was their only real outcome. All of them were successfully reduced, by the way. They didn't have to have any rescue or go to the OR or anything like that. Explicit statement that they were recruited consecutively. No, we don't actually know how these patients were recruited. Like I said at the beginning, I'd imagine they were just convenience sample. It was when they were working and they said, okay, these are good patients. We don't really know. Prospective data, yes, it's basically how it was run. They didn't talk about any of the data, any other data, because there was a yes/no question. It was, is there pain control, yes or no, and are there side effects? We don't have any confidence intervals. We don't have any dose curves. We don't have any of that stuff that you would expect from a pilot study. And reporting of mortality, recurrences, and complications, I said yes, because we have some side effects or adverse effects from it, but we don't really have anything else. We don't know if the patients came back the next day or the next 3 days. Or even an hour later because of side effects. We don't know anything else about the patients except for the fact that they left the ER after they were reduced. So that's the end of that one. I thought because that one was kind of short and only 4 patients, and not a great study and not as relevant to EMS. I wanted to highlight something that was in the same ballpark that's more relevant for EMS, which is this article. Can nebulized naloxone be used safely and effectively for EMS and suspected overdose? And the reason I wanted to use this article as in addition is because it was actually done by the Chicago EMS services. It was purely EMS study to see if it would work in EMS. And it's something that I've actually done in the emergency department myself. So a little bit more relevant, they used Chicago EMS. They are a 220,000 annual transport multi-tiered system, almost all fire-based. I did a rotation in Chicago and they're very, very well trained. Each call that they did that was an AMS or an altered mental status call had as an ALS response specifically, which I think is pretty normal. And every person in Chicago EMS is under the same med control. So the population of cases that they studied was 105 specific cases. These were the 3 areas of altered mental status. There was a suspected narcotic overdose, a respiratory depression, or just a bare bones altered mental status. They had some exclusion criteria, again, because this is for opiates. Anything that was opiate-induced asthma they thought was not going to be appropriate because you're going to need to give them bronchodilators rather than just naloxone, and likely it's not necessarily an overdose. They had incomplete outcome data, so what they did was, and I'll talk about this in the 2 slides, but they looked retrospectively, and if there was any of the data missing from a paramedic chart, then they didn't include it in the study. If it was an impending or active cardiopulmonary arrest or apneic respiration, so basically the patient had to be able to have their own respiratory drive in order to take to actually receive benefit, similar to what we do with nebulizers. No comparison group again. So what they actually did before they did this protocol change is they actually did a 4-hour didactic session where they sat paramedics down, discussed everything about it, why to do it, the pharmacology, everything, and they did a field drill. So you went to the field with a supervisor or med control, and you actually had somebody making sure you adhere to the protocol directly before you were able to do it out on your own. And they used this dosing for naloxone, 2 milligrams of naloxone with 3 milliliters of saline. The primary outcome was just basically response to nebulized naloxone. I highlighted in green the ones that were basically very different. The majority of all of them, complete, partial, or no response, were male, which probably goes along with the demographics that we see. The age range, mean age was about mid-40s. The dose was about the same because it was the protocol. You need 2 milligrams is the protocol. That's basically what they're going to get. But what we see is 2 interesting points is that the longer it took for the patients to get the nebulized naloxone, the less likely they were actually to have a complete or partial response. And we also noticed that there is the respiratory rate is actually interesting. They have a higher respiratory rate in the no response, which I'm not sure what to make of that, because you would think that that would actually be beneficial. GCS was about the same, and time to hospital transport was about the same. The big things were, okay, well, do you need to give them naloxone after? And only 10% of cases needed IV or IM naloxone afterwards. From the article, they didn't talk about intranasal. It was just IV or IM as the rescue. Did anybody need to have BVM assisted ventilations, intubations, or did they die afterwards? And they had the only secondary outcome they actually had was 10% needed the IV or IM naloxone of the patients that were studied. So I thought, again, this was a more interesting and relevant, something that we could probably bring into clinical practice today. So what's the quality checklist? Did they address a clearly focused issue? Yes. Did they answer their method did they use an appropriate method to answer their question? I believe so. They had, it wasn't independent observers. They just used the paramedic charts. And with the paramedic charts, so it was like a retrospective after protocol change. So it was kind of like a before and after type of situation. But what the database that they actually used where their charts go are independently monitored by not just physicians, but also other paramedics, so that you know that it can be independently audited. But they didn't have independent observers. So I could say that the patient's respiratory rate was 12, but Steenberg could say that the patient's respiratory rate was actually 16, and that just, as we know from working on the road and working in the ER, that's very common to not be independently observed. That's kind of, okay, yeah, we're kind of guesstimating in that sense. So there are some biases in that. Was the cohort recruited in an acceptable way? Yes, it was basically an altered mental status that you thought it was a suspected opiate overdose, not currently in cardiac arrest. Exposure accurately measured to minimize bias. That's kind of what I was just talking about. I'm not really sure because it wasn't an independently observed or intervention. Outcome accurately measured to minimize bias. The confounding factors were identified. I believe that they were, but again, audited. Well, we don't know if they, what happened to them in the ER. Basically, we just know that they made it to the ER. They didn't need any intervention besides 10% needing BVM by the time they got it to the ER. We don't know if they rebounded or something like that. Again, it depends. Do you believe the results? I say yes. I've actually done this in the ER, and I'll talk about it in the next slide or two. These patients tend to come out a little bit calmer. You're not slamming them with 4 Narcan, then putting them into pulmonary edema, making them agitated, and then giving ketamine, which, again, I'm sure we've all seen multiple times. So this is a way to give a lower dose at a little bit of a controlled setting to hopefully, allow them to come better. Can it be applied to the local population? I'd say yes. Anywhere that we all work, it can be. Then cut out. Last 2 slides. So the author's conclusion was it's a reasonable option. One of their big things that they mentioned was if you're not using needles to do IV, IM, or even intranasal when you're drawing up the medication, depending on the way you carry it, you're not getting accidental needle sticks, which is something that we don't really talk about as much, at least that I feel like we don't talk about as much. Is it's a safety issue. Anytime we draw medications or anytime that we are giving medications, there's always that concern of, okay, if I start an IV, I can stick myself. We don't know if the patient has HIV or hepatitis or any other bloodborne pathogen. So it's something to consider. Like I said, less patient agitation. I've seen that myself, and less side effects. You're not throwing them into pulmonary edema. My conclusion, I've talked about it already. I didn't see any obvious confounds. It's a low risk intervention that we can implement in the ER. I know New Jersey protocols are New Jersey protocols, so theoretically we could introduce this into the EMS setting. Today, tomorrow. Not necessarily true in New Jersey, but again, something that we could consider for the future. That's all I've got.
Yeah, I've used this several times, especially in the ER when that patient who is breathing pretty much okay, but isn't quite there. Maybe they're breathing just a little bit too low. They're not hypoxic, but they're getting there. And you just put the nebulizer on, and it perks them up. Their oxygenation gets better, and you just leave them until they start to come out of it themselves. Anyone else?
Yeah, I would actually. It's kind of funny because this is kind of like an accepted disobedience. It's pretty widely used by most of the medics on the street now, especially you guys up in Newark. I mean, I worked up there for a long time. It's pretty widely used and works amazing on a lot of these patients that are just on a little bit of a nod. And a lot of these patients are the ones who will come in the hospital and they say, I'm fine, I'm better, and walk right out. it does seem to work really, really, really well. And it's something that almost every urban agency I've been around, they do kind of interestingly charted.
Yeah, I think the original paper came out like almost 5 years ago now, right? Amandeep, I know you. I think Amandeep was the one who introduced me to it. Aman, you there?
Yeah, I'm here. So yeah, it's something that I really kind of enjoy, that I'm kind of really used to doing. Um, Basically, the one thing I love about it the most is that it's really titrated to effect. So what that means is that you're giving the patient a nebulized treatment, and what ends up happening is, as soon as the patient starts becoming more alert and waking up, what ends up happening is they actually take the non-rebreather off themselves. So you're not going to really give them a super dose to where they're going to acutely withdraw, because as they're coming into consciousness, they're basically going to take that mask off. The biggest difference, I guess.
To go, I think you cut out.
I think his beard hit the mute button.
Can you hear me now?
Yeah.
Yeah.
Sorry about that. I think my beard did hit the mute button. Anyway, move it away. So anyway, so the patients, I don't know where I kind of went off, but what's the indications of giving Narcan basically in the field is patients who are agonally breathing, or who are hypoxic. Those are the patients that you're ventilating with a BVM, and you're going to give them the Narcan with IV or intranasal to kind of acutely reverse them from that process. But if you have someone who's breathing 10 times a minute, and statting okay, is that someone needs IV Narcan? In my eyes, probably not. The question is, you can put end-tidal on them and see how they're doing, or you could slowly kind of reverse them. The difference is the EMS, we're not watching them for a long period of time. We're going to either take them, reverse them, sometimes RMA them, or we're going to take them, reverse them, and bring them to the hospital. The other flip side is that if they're in the back of your rig, do you really want to acutely reverse somebody and then have them become combative while you're in transport? Single provider, putting them at risk. So for me, the benefit versus risk is if I give them nebulized, they're slowly coming out of it. They're going to titrate to effect. They'll take it off themselves. My crew is safe, and we're not putting them in harm's way either. So it's a win-win situation, really, in my eyes, because we know that these patients won't become combative. They're not going to try to they're not going to vomit all over me. They're not going to try to escape out of the ambulance. So really, in that scenario, the nebulized kind of wins. The difference is that, transport times and how long are we holding on to these patients. Ultimately, for us in the emergency department, I do like to do nebulized because I'm slowly kind of taking them out of their high, but at the same time, I'm not going to cause any ill effect. Like, Frank kind of talked about pulmonary edema, acute withdrawal. I've seen people who've given IV Narcan, and then what happens is they withdraw, they vomit, they aspirate, they become hypoxic, then they get intubated. That's the kind of complication that we never want to have on a patient. So, trying to slowly, reverse them, and then, having them be able to be discharged a little bit sooner than what they would normally have done on their own is an optimal kind of compromise, I think, from the practitioner side and the patient side, and without doing, any undue harm. But this is something I started doing a long time ago, and I've been a big fan of, and I routinely still use it.
Anyone else with the nebulized Narcan? I love it.
How do they document it creatively in the chart? Man.
I can't really give away all the secrets, but so the whole thing when it comes to being a medic is, how do you know what I gave? I have to be honest and tell you what it is. So I can call you and get an order of 2 milligrams of Narcan intranasally and just put that in a setup and give it. And by the time I get to one of the hospitals, that asthmatic patient who is on the nod is now awake and they're able to breathe and they don't have that bronchospasm anymore. No one's really the wiser as how you gave it to them. That's one of the interesting things when it comes to EMS, and especially in New Jersey. There's a lot of handcuffs that they put on people, but anybody who's been around for a while, you have to be able to kind of read in between the lines and see like what was really done, what was documented, and what really works. And and unfortunately, not all of them meet at the same pathway all the time. And yeah, this is one of the things. This happens quite frequently, especially in a lot of the urban environments. It's a lot easier for me to, especially if you're just kind of stumbling, you have a little bit of, you're awake a little bit, put a little bit of nebulized Narcan in it. By the time I get to the hospital in a 5-minute transport, you're slowly awake, and I can put you in a wheelchair and wheel you right in. It's not the right thing to do, but it's
himself.
Play.
But yeah, like going on along with the first article we talked about, sobering centers, I think this is a pretty effective way to just get them out the door, right? Right after, you know, they're sober enough, they're walking around, they're awake, and they walk themselves out, you know, that's enough. And I think that kind of saves you a bed and gets them out sooner. That's something I've been ordering as far as like when I was a third year, second year, I was asking the medics to actually give these nebulized treatments prior to actually arriving, because once they arrive, they're sober enough, do a quick eval, get a set of vitals, and they're on their way out. And I think that saves you, you know, a bed, and that's kind of what we need, especially in an urban hospital like NBI, you know. As far as your first article goes with a ketamine article, I think that's actually a very interesting way to give ketamine. It's something I think I would want to try, but I guess more studies have to be done as far as whether that ketamine is actually as effective as, you know, other dosing, and whether IV might be a better option. I think we could probably do like a study like that for shoulder dislocations or something from NBI. Be interesting to see how effective it actually is, because it is a narcotic, and I feel like most people would probably jump to like morphine or, you know, some kind of narcotic for pain relief, especially for some kind of traumatic ortho event. Has anyone actually tried ketamine for in like a nebulized form? And also, would you consider this like a procedural sedation or purely for pain?
So I've used ketamine for I've nebulized ketamine myself. I've actually done it for asthma as well. It actually works pretty well in asthmatics. So it is another type of modality that you can use, asthma and pain management. You know, ketamine is frequently being used now, more so than often now, for pain management. Last night, I actually got a call for pain management with ketamine. You know, so I mean, you know, I gave those orders. So I mean, you know, those are things that you kind of like, you know, some patients, you know, who maybe are refractory to narcotics and you want to try something else, you know, ketamine may be an option. I was interested to see that anesthesia was using, you know, nebulized ketamine for the post anesthesia cases. I would have thought that they probably would have nebulized lidocaine. I've nebulized lidocaine quite a bit, and for like airway kind of anesthesia, and it works really, really well.
Like coughing, something else.
You could do coughing. You can also do prepping for.
Generally, like for coughing, like people who just have persistent coughing and they're like, nothing else is working, I'll just give like a quick 5 cc, like 2% lidocaine treatment, and it usually works for like 2 hours.
Yes, it works really well for coughing, especially in kids. You got these kids who have got like these spasms, and then they're like kind of bronchospasming and they're coughing quite a bit. You know, this is one of the things that really works for them, is nebulizing the lidocaine. You know, I've used it also for kind of airway preparation. So I do a lot of, I'm sure you guys know, I bronch a lot of patients in the ED, and I kind of, you know, examine their posterior pharynx for even foreign body or kind of airway expected management. And so, you know, prepping that airway, you can nebulize lidocaine, and actually, you know, you're able to visualize the airway a lot more easier without the patient gagging or giving any resistance as you're kind of passing the fiber optic scope down. So, you know, those are all different modalities that you can use, but, you know, nebulize is the ticket. It's the new wave. We've nebulized TXA before. You know, you got patients who are having, you know, pulmonary hemorrhage, people who are, you know, hemoptysis from like some type of cancer, and, you know, they're persistently coughing up blood. I've given orders for nebulizing TXA. So, you know, lots of cool things that you can do, you know, from the nebulized format. I think this is kind of the new wave of how we're going to be administering medication.
Yeah, so we unfortunately, it's actually probably easier to implement something like this on our EMS rigs than in the hospital, because in the hospital we have to put this through P&T, Pharmacy and Therapeutics Committee, but it also depends on the hospital. Um, in EMS, as the medical director, we have to talk to the clinical leadership board. We have to look at policies and procedures, and then based on that, we can actually implement this ourselves. And also, we can actually easily do a study on this. We were already working on a study with low dose IV ketamine for pain control. What I found was that because a lot of people didn't, they didn't grow up on, ketamine for pain control, it was very difficult to get them to use it. And that's just about being familiar with the product. Another issue that can come up, and especially why this is actually a very important thing to be looking at, is, non-narcotic pain control is extremely important right now and nowadays. And our pain control options for EMS that are non-narcotic are almost nil. It's basically, control it with magic.
Hot pack.
Something that's been looked at a lot too for years is, and I think slowly coming back, is inhaled nitric oxide too for pain control. They started doing it in Florida as I was leaving, or at least had the hookups for it, because those studies started coming out. So, I mean, it's, again, same thing with inhaled ketamine in the ER. It's something that would be great to try and use, or at least study, but there's a lot of red tape to say.
Yeah, so one way that we implemented, I was using nitrous oxide in one of my medic units in New York, and the way that we handled it was we would have the people, whenever you used it, we would just change out the canister. Because one of the things that you worry about is, product loss and abuse and things like that. And basically we treated it like a narcotic. So we had to sign in, sign out, you put your seal number when you used it on a patient. After that, you'd bring the canister back and exchange for a new fresh sealed canister. We actually on the physician vehicle we have it. We haven't really used it, but it's available, and we can talk about that when you're doing your rotations. Anything else? Anyone
I
want
had
to
a
add
quick
it?
question actually about are there any issues like with the repeat dose of nebulized ketamine, like a higher incidence of maybe side effects or something like that if you have to kind of use it again second time?
So I think in this study they only gave one dose and that was it, and then you went straight to rescue. In general, a lot of these nebulized products, it's kind of like you're given a continuous dose. So you put your dose in, you let it run, and then you're not repeating it. So, and in all kinds of medications, especially moderate sedation, things like that, I personally would rather give a large first dose than give multiple small doses, because I want to know when it was given. The half-life, when it's going to happen. You get into trouble when you're repeating dosages and kind of be like, well, did the first dose wear off and now my third dose is going to kick in later, and that's how you kind of get in trouble.
Right, makes sense. I also had a quick question about the naloxone article. Kind of the speed at which, I guess I'm not really familiar on the bus. Like, if you can, is it faster to give it, naloxone maybe intranasally, or can you get it to the patient pretty quick nebulized?
I mean, it depends on how you have it readily available. I mean, theoretically, it's easier and quicker to do it intranasally or IV or IM. But the whole goal of this study was to prevent, complications and allow them to come out spontaneously. So one of the ways, they were mixing 2 milligrams and 3 cc's of normal saline. You could have that pre-mixed, kind of like we do our duonebs, and put it in a nebulizer and give it to them. That might be a way to decrease the time to that. But the whole goal was kind of give them a gentler way out rather than just slamming them.
Slamming them. Okay.
Yeah, a lot of these patients, you're not giving them. These aren't your patients with a GCS of 3. These are the patients that are kind of they're just somnolent. I've never seen anybody do it on like a person who has a GCS of 3, but they usually have a little bit of a respiratory drive, and you're able to sit them up, put them on the nebulizer, and within 5 minutes they wake up slowly, like the course said before. They take the mask off themselves, and that's when the dose is over.
Very cool. Okay, so I would imagine, yeah, if they have no respiratory rate at all, like they're probably not going to be it's not going to be too effective with the nebulized treatment.
No, we're pulling out the needles for that.
Perfect.
Well, with those patients, you can't nebulize them because you're ventilating them with a BVM, so it's counterintuitive.
I mean, we could. It's just more difficult.
So,
but yeah, Travis, think of it like asthmatic that you're getting duonebs for. If they're not actually ventilating, then that's why we use TURB and Epi IM, because that would actually get the medication. Although it's just like systemic, it will get the medication to the desired place of effect, which is the lungs, right? Like the duonebs won't actually get to the lungs if they're not actually ventilating, like for asthmatics. So same kind of principle.
And the other thing, you mentioned about the ketamine. One thing, I love ketamine. I'm a big fan of ketamine. The one thing I will say with ketamine is that there's a slippery slope. And what I mean by that is that there's this, analgesic phase that you can get. There's this dissociative phase that you can get. You can get a sedative phase, and then you can get a K-hole phase. So, and we never want to drop them into this proverbial K-hole, but the problem is ketamine is very unpredictable in that regards. And so when you give it in certain aliquots, what can happen is that you can push the patient from analgesia to being disassociated. And then or even sedated. So, I mean, depending on the amount of dose that you're giving, how often you're giving it, typically ketamine you want to give over 15 minutes. You cannot let it right in. You can slowly give it in aliquots as well. But these are lower dose medications. And the thing with ketamine, especially when you nebulize it, the problem is that you're probably not going to get the full dose either that you're delivering, because it all depends on the patient's respiratory drive, their respiratory effort, what their true tidal volume is, how much they're able to take it in. If they're tachypnic, and they're in pain, the question is, are they really getting a good amount in? And then, are you setting your oxygen, rate at like 6 or 8 or 10? If you're dialing it up higher, they're not getting enough of the medication. So it's hard sometimes to really quantify how much they're really getting. And that's one of the things about neb treatments, right? And when we talk about even intranasal medications, when the volume becomes higher, we know the effective dose that they receive is less. So the same principle exists with nebulized medications. We truly cannot quantify the exact amount of medication that they get. So when we talk about giving someone maybe 20 milligrams of a medication and we're nebulizing it, are they really getting that dose? And it may be variable from one patient to another. And so really kind of watching these patients and then kind of reassessing them and determining whether you want to give them another dose, you would do that, but do it carefully. And I think you have to wait a decent amount of time before you really do that. And by that time, you're probably at your destination site. And so sometimes it is important to, maybe reassess and reevaluate. One of the classic examples that we use commonly in the field is fentanyl. We use fentanyl for trauma patients or for other patients who might have some type of pain. But the thing about fentanyl is that, hemodynamically, it's very good. It helps your blood pressure, maintains your MAPS. But it's life, the half-life is so short that you end up having to redose the patient quite often. And we're comfortable doing that, and we know because we see the patient in front of us, they're awake, they're alert, they're still in pain. You see the pain coming back, they're becoming a little more tachycardic, a little more hypertensive. So you can dose them again. Same kind of concept with ketamine. I think we just have to get more comfortable with it, get used to how we're delivering it, and then kind of continue to use it. All these medications you just have to get used to administering, and then kind of perfecting your dosing regimen and pattern.
Mandeep, I think you hit a couple things on the head that have been running through my mind during most of these presentations. One about, and Travis, your question about intranasal, a lot of intranasal medication dosing ends up getting swallowed because it gets blown right down the back of the nasopharynx, and so it's not really an effective dose. versus a nebulized dose. And I know that you were using a slightly different device in one of the studies. That was interesting. I'd be curious to look at the actual delivered dose. We don't have an easy way to do that, but that would be an interesting thing to take a look at. And obviously it's right patient to the right route, at the right time. I mean, somebody that's unconscious gets one route, somebody that just needs a little bit of touching up gets a different route, kind of thing. The ketamine that was interesting, that was 1.5 mg per kg. You can argue ideal versus actual. Traditionally in an IV dose, that's pretty close to a sedative dose, and that's conscious sedation without really any questions. So is that mostly not being absorbed? Because that's a very different dosage relative to what we would normally do for pain control. It's in a different route. Amandeep, you also talked a lot about, that kind of hole in the middle in ketamine. The sedative doses are a lot higher, the pain control doses are a lot lower with that dissociative state in the middle. And that's sort of the danger zone of ketamine. And so learning when to redose ketamine, especially if you're trying to stay in the pain control range, is I think a tricky thing to learn, because you put yourself pretty quickly into that danger zone. So, it all speaks to having experience doing this and some guidance from some folks so that you can select the right therapy for the right patient.
Yeah, and actually that's one thing that I was asking myself while reading through it is, they gave the 1.5 milligrams per kilogram dose, which we typically think of as like the conscious sedation dose. And then which concentration are they using? Are they using the high concentration that we use for intramuscular, or are they using the lower concentration that we typically give IV? And if you're going to do this and you thought that a nebulized medication you're going to lose 20%, like we talked about with the other article, then are you getting into a deal of, if I'm looking at pain control with, I think from what I was taught in residency, a maximum dose of about 0.3 mg per kilo IV, do you start trying to calculate that in your head as far as what would be the appropriate inhaled dose? And I think there's a lot of things that you could look further into when it comes to this, but it'd be interesting to kind of see, what the options are.
I think the one caution I would have is that if you are interested in using ketamine in more of a conscious sedation style, I don't think that's what we're talking about here with inhaled ketamine.
No, I'm talking about for analgesia.
No, sure. Yeah, I would just throw that caution out there so that people separate the two in their minds, because conscious sedation, I think you want some sort of a rescue line in place, et cetera. And unless you're going to drill the patient immediately, with a line, if you're already establishing a line from a safety standpoint, why are you sitting there? You have to find some other reason why you think that you should be inhaling the ketamine instead of just pushing it IV. Maybe there's a better safety profile with some side effects, things like that, relative to fast and slow pushes. Who knows? But yeah.
And just to kind of get on a soapbox for orthopedic, kind of injuries and pain management, EMS, emergency medicine, across the board, we do not treat long bone, not just any orthopedic. I'm talking about long bone fractures appropriately with pain management, and we don't treat them early on. And there's so many times where I've come on the scene to, a slip and fall for an elderly patient, and I come to see, the crew kind of trying to move the patient and trying to get him in the back of the rig. And I said, guys, what are we doing? You splinted the limb. You're trying to throw him in the on a Reeves, and you're trying to throw him into a stretcher and then bring him back, and then you'll start a line and give him pain medication. Before we start moving this patient, let's just give him something quick, intranasal. Like give him something quick for pain management. Even IM, it doesn't matter. You don't need to start a line to give him something for pain. But before we start moving these patients, we've got to start giving them something for pain. And early pain management for long bone fractures is something that we don't do well. Emergency medicine across the nation and EMS across the nation, I'm not sure why we believe that we splinted it and we're doing okay. Immobilizing the limb and we're good, but just immobilizing it isn't going to help. You've got to treat the pain, and we're talking about long bone fractures. Lots of studies have been done, and we've time and time again have failed to treat pain appropriately. That's
I
all.
think some of that is because of the lack of available options for the BLS provider. And and most people do a career in BLS first for a while, and you kind of get used to it. You don't have anything to give them, and so you splint it, and you got to move the person anyway.
Well, you're also taught that by splinting it and stabilizing the fracture, you're going to help with the pain control. But I mean, as long as you're not moving them, that's true. But what are we doing? We're transporting patients.
So you get into this situation where you're used to not really providing effective pain control, and then obviously this is one of the ways that a two-tiered system can sometimes work against you. There are plenty of times where and I've actually gotten it myself, even as a physician on scene, where ALS has given you pushback for sticking around for pain control, or BLS doesn't want to call ALS back for pain control. Like, oh, that's not a valid indication.
But it is.
So.
Yeah, I mean, don't forget the intranasal fentanyl for pain management. It's so important, so easy to do. You don't have to put a line in the patient, and you can actually give them a significant amount of relief of pain.
All right. That wraps up this edition of Journal Club. Dr. Norris will be running the next one. We have to decide on when we're going to do that. It's either going to be the 3rd or 4th week of next block, and we'll see if the emergency medicine residency wants to join in. We can bump it up to noon, but we would have to do that now, not the day before. So let me just